let's get 2 minutes on the clock and your time starts now. All right, time is up. Let's have a look at the answers. Admittedly, this is a question that you probably wouldn't get in the actual exam. The wording of it's not fantastic, but really what we're looking for is what are the things we would look for secondary to fracture? What are the things downstream of that we're going to be worried about occurring? And so the big thing really is that neurovascular compromise. So the absence of radial pulse in the affected arm, or you could just say distal pulse. Signs of ischemia or pallor in the hand would be lumped into that. It's really a perfusion kind of thing. Likewise, cool temperature of the hand as well would kind of get lumped into there. Severe swelling in the forearm or elbow, suggesting compartment syndrome. So what are we looking for and what are we concerned about? Skin puckering or dimpling over the elbow. Again, concerns around that compartment syndrome effect. Anterior bruising at the elbow, signs of hemorrhaging into that space. And of course, evidence of neurological injury, weakness or paresthesia distal to the injury. Wording of that one's a bit shoddy, we'll say, sorry. But really anything that kind of specifies we're looking for that altered nerve activity distal to the injury side. Each of those things is going to be worth lots of marks. This is one of those things, it's a red flag question where they're wanting to know, do you know the dangerous things to be looking out for in a patient in this position, especially a case like this where this is a not uncommon presentation. Now take note as well that this is presents to the emergency department, so consider the work site in your answers as well, and that might be a bit more relevant for upcoming questions as well. So looking in the chat here, we've got left pinky cup refill under 3 seconds, left pinky tip numb to light touch. So we've covered vascular, we've covered neurological, left into digital power 2 of 5. So again, probably a bit of overlap there in terms of really they're both kind of nerve type responses. So I'd try and diversify a little bit if you can. And probably use something more like the skin condition or swelling, puckering, those kinds of things there. But otherwise, fantastic answers. Excellent. So, what could come next, I wonder? The fact that I've had the Royal Children's Hospital up there for fracture management, I think most of you can probably guess where this is going. So, let's get 2 minutes on the clock for the next question. Your time starts now. All right, so let's have a look at those answers. Of course, there's always going to be some kind of interpret this ECG, X-ray, clinical photo type question, and they try to find photos where it's going to be relatively obvious what the actual thing is, bearing in mind that these have to be physically printed out and delivered to sites all across Australia. The print quality is not always the best, and so they have to try and take that into consideration and find things that aren't going to trip people up too much. If you want full marks here, this is a Gartland 2 supracondylar fracture of the left humerus. So that will get you 3 marks. We've said what it is, where it is, the grade of it as well. You could just specify a supracondylar fracture of the left humerus, getting 2 marks, or just supracondylar fracture or humeral fracture, 1 mark. So depending on how much detail you put into there. And we can see here, this is a case taken from Radiopedia. If you're not familiar with Radiopedia, become familiar with Radiopedia, just like things like DermNet as well, if you're not using it. They have heaps and heaps of cases up there that you can practice, test yourself on, I mean, let's be honest, it's where RACGP gets a lot of their photos from for the exams, these kinds of sources. So the more you're using it, you may be surprised what pops up in the actual exams as well. Everyone that uses DermNet has giggled when they've seen photos pop up in the exam. They're like, yep, okay, I know what this is, not because I know what this is, but because I've seen this photo before. Excellent. Now, you can see here from the radiograph when they've drawn the green line of doom here, which is actually showing that posterior displacement, the angulation of the fracture there of the distal humerus, the supracondylar. Here we go. We have from Baba a type 3 subcondylar fracture of the left humerus. And you know what? I think you would actually get the marks for that as well. Given on this photo here in particular, printing and screens taken into consideration, I think they would give that. There is just that little bit of cortical contact just at the distal posterior section. Admittedly, it's not much. So technically it is 2, but I think they would give you full marks for 3, given the quality of the radiograph provided. So very well done, mate. Very, very well done. Excellent. So we have one final question on our last case. Let's get 2 minutes on the clock, and your time starts now. All right, time is up. Let's have a look at some of those answers then. So first thing, of course, is to take into consideration this is a kid with a fracture, so we want to be providing some kind of analgesia, some kind of pain relief. Now it has specified vital signs are normal, so you can hope that pain's not too severe. So I think as long as you're giving some kind of sensible option, like oral ibuprofen or paracetamol, something in that kind of territory to start off with, this is immediate management, I think you get the marks. You also want to be immobilizing this left elbow with a back slab in 90 degrees of flexion. So we're specifying what we're doing, which side, and how we're doing it. So back slab, 90 degrees of flexion, full marks there. There's going to be a referral for urgent orthopedic consultation for fracture management. So the urgency, who it's to, what it's for. Elevate the arm to reduce swelling / prevent compartment syndrome. Now, if you were to put that exact sentence in, you would be losing marks. That's definitely overcoding. So I think as long as you're putting something in that kind of territory, you would get a mark. And of course, perform and document a thorough neurovascular assessment pre and post immobilization. You might get a mark there. I always try to throw something like this in to say you're acknowledging how good or bad it could go. So you need to document pre and post. The thing that mucks this up, for this question at least, is the immediate management. So that might be more kind of medium-term management in terms of documenting pre and post. But I think you might, at a stretch, get a mark in there if you can't think of anything else. Let's have a look at the chat then. So here we've got immobilization. Good. I'd probably get a little bit of more information into there. External reduction. To be honest, if it was me in ED, yeah, I probably would, to be honest. I agree with you there, just given that level of movement. I think if we're looking at it from a GP perspective, average GP working in ED, they might be happier to just say refer to orthopedics to do that. But if you've got the skill set and experience, I think it's something that an experienced GP with experience in orthopedics could also perform as well. Diclofenac injection for pain relief. You know what? Yep, fantastic. And diclofenac is a brilliant analgesic that I think a lot of people actually forget about. So, yeah, look, I think while I've gone the oral route, I think it's not a terrible choice for this kind of patient there. So, well done. And we've got a little note from Kesh. Hey, Kesh. Back for revision. Of course, you can't hold me back. I'm always going to cause mischief. Excellent. So, hopefully you're happy with those answers. I can see most people seem to have put in things pretty similar to that, so fantastic to see.